It's that time of year. ACR Convergence 2024 is nearly here. Join us in Washington, D.C. from November 14th to the 19th. Meet up with colleagues from around the world. Enjoy thought-provoking sessions, listen to groundbreaking science, and join us for the Knowledge Ball, Thieves Market, and the Image Competition. Register today at rheumatology.org. ACR Convergence 2024, where rheumatology meets. Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. As rheumatologists, we are very familiar with pain. Sometimes pain is a symptom of a disease or a sign of a flare, but sometimes pain makes medical decision-making complex. The manuscript we will discuss today is Prevalence of Fibromyalgia and Widespread Pain in Psoriatic Arthritis, Association with Disease Severity in a Large U.S. Registry. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. It is a great honor to be joined today by the first author of this study, Dr. Philip Meese. Dr. Meese was the Director of Rheumatology Research at the Swedish Medical Center and Providence St. Joseph Health, and is a clinical professor at the University of Washington School of Medicine in Seattle, Washington. His clinical practice is based at Seattle Rheumatology Associates. Dr. Meese earned his undergraduate and medical degrees at Stanford University and completed his internal medicine residency and a rheumatology fellowship at the University of Washington School of Medicine. Dr. Meese is a past president and founding organizer of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, fondly referred to as GRAPPA, and is a member of the Assessment of Spondyloarthritis International Society and the Spondyloarthritis Research and Treatment Network. He has also been active in the Outcome Measures in Rheumatology, OMERACT, research organization as a co-chair of the Psoriatic Arthritis and Chronic Pain Working Groups. Dr. Meese is also a master of the American College of Rheumatology. Welcome to the show, Phil.
Thank you for having me, Vicky.
So let's kick off our discussion by delving into this complex world of pain. As rheumatologists, we're all too familiar with the various forms it can take, from a symptom of disease to a complicating factor. But why is it important to study the role of fibromyalgia in chronic inflammatory diseases like psoriatic arthritis?
The International Society for the Study of Pain has classified 3 types of pain mechanisms: nociceptive, neuropathic, and nociplastic. Nociceptive pain is the pain that we most think about as rheumatologists when we're assessing a patient and hearing about pain in that person. And typically that is going to be due to either inflammation or mechanical irritation, leading to excitation of nerve tissue that sends signals to the brain and is interpreted as pain in the brain. So that's, you put your finger in a candle flame, your reaction is to suddenly pull it out, and that's all because of a nociceptive signal having been sent to the brain. Neuropathic pain is pain caused by actual disease of a nerve. And an example of that would be diabetic peripheral neuropathy. And then there is what is called nociplastic pain. The latter was codified in 2016 and took the place of the phrase central sensitization pain. This is pain that's experienced not necessarily because of any peripheral nociceptive input, but instead is pain that is experienced at a central level, both in the spinal cord and various centers in the brain. And typical examples of that would be the pain of fibromyalgia or the pain of irritable bowel syndrome, for example. Now that we have better ways of distinguishing these mechanisms through either subjective questionnaires as well as objective measures such as neuroimaging, we increasingly recognize how important it is to understand what mechanisms are operative in the patient in front of us to optimize their pain treatment. In particular, we recognize that fibromyalgia is a common concomitant reason for pain and other symptoms such as fatigue in up to 20% of most rheumatologic conditions, and needs its own pharmaceutical and/or non-pharmaceutical treatment, including patient education, in order to improve, and if nociceptive pain is well controlled, not chasing residual pain by changing from one immune moderating medicine to another.
That's a really helpful explanation. Now, the data set you used for this study is the Core Evitas study. And for those of our listeners who don't recognize the name, this is like a pop star. It is the longitudinal data set formerly known as Corona. I guess the study changed its name sometime after COVID-19 began, which makes a lot of sense. Could you share some background on this data set? How long has it been ongoing and who funds it? How many patients are enrolled, and how could investigators potentially access the data set for research?
Corona was the brainchild of Joel Kramer, a rheumatologist in Albany, New York, who recognized the importance of having quality registry data on rheumatoid arthritis and psoriatic arthritis patients to generate real-world evidence about disease state, natural history of disease, comorbidities, treatment effects, and importantly, drug safety. The name Corona stood for Consortium of Rheumatology Researchers of North America. It was kicked off in 2001, and our center has been part of it since 2003. Now, over time, Corona has evolved and now has registries involving dermatologists who study psoriasis and inflammatory bowel disease specialists who study IBD, and clearly has grown beyond rheumatology only. So that was one of the reasons for the name change from Corona to Core Evitas. But there are other reasons, as you noted. It happened during the pandemic, and we didn't want to have any confusion between the coronavirus and the Corona registry. So there we go. In the 2012 timeframe, I was working closely with Joel and other leaders in the registry, recognizing that we weren't really studying psoriatic arthritis adequately. We were collecting information on joint disease as we were in the rheumatoid registry, but not all the complex domains of psoriatic arthritis, including skin, nails, the spine, enthesitis, and so on. So because of that, and also because we weren't collecting data on ankylosing spondylitis patients, or as it was known at the time, ankylosing spondylitis, now known as axial spondyloarthritis, Joel and others agreed that we should have a separate registry for PSA and AxSpA. The RA registry currently tracks over 50,000 patients with that disease. The PSA and AxSpA registry, going since 2013, tracks over 8,000 patients. The registry is supported by sponsorship from various pharmaceutical companies. It is under the umbrella of a corporation known as Thermo Fisher. Now, those of us that are part of the registry can take part in clinical studies, inquiries of the registry database, and so forth. Investigators who are posing questions who are not part of the registry can apply to the Corona Foundation with project ideas. And this particular study that we're discussing today was one that arose from the Corona Foundation.
That's great. Thank you for that background. It's really helpful to understand that. So Core Evitas collects two measures of widespread pain and fibromyalgia, the Widespread Pain Index, or WPI, and the Symptom Severity Scale, or SSS. What do these measures involve? And is there also a physician assessment involved in the data collection?
The WPI and SSS questionnaires were developed by Fred Wolf and other researchers interested in fibromyalgia, including myself. The original version of these measures was published in 2010, called the preliminary ACR fibromyalgia diagnostic criteria. In Core Evitas PSA ACSPA registry, we are using the revised, more simplified version published in 2016, and we've been administering this to patients since May of 2020. The WPI assesses the number of body areas in which the patient regularly experiences chronic pain. The symptom severity scale assesses the presence and severity of other often associated symptoms of fibromyalgia, including fatigue, sleep disturbance, dyscognition, headache, abdominal pain, and depression. If you have a high WPI score, that corresponds to having a significant amount of nosoplastic pain. And if you have a high SSS score, then that gets to defining the more multidimensional aspects of fibromyalgia. If represented as a Venn diagram, those fulfilling WPI criteria are a larger circle, and those also having high SSS, defining fibromyalgia, a slightly smaller circle. The WPI can be used on its own, but we get most information if the two are used together. Although Fred felt that these were best administered to a patient with a clinician present to help elicit this response from the patient, for practical reasons in the Core Evitas registry, we use it as a patient-reported set of questionnaires and find that to work quite well.
And what can you tell us about the providers who enroll patients in this registry? I think there are 302 providers from 65 sites across 30 US states. Are these providers community rheumatologists, academic rheumatologists, or both?
The majority of the investigators in Core Evitas are community rheumatologists, but there are definitely some academic center rheumatologists involved as well. And one of these, Alexis Ogdi, is also an epidemiologist that I work closely with to help understand the data sets.
Fantastic. It's good to hear that it's a real mix. And I think it's so important actually to get sort of real world data on these longitudinal data sets. So tell us a little bit about the methods you use to pull the data. It looked like this particular study was a single time point cross-sectional analysis. How many patients were included and what were the inclusion and exclusion criteria?
We analyzed 1,823 patients with psoriatic arthritis who had completed the WPI SSS questionnaires over the last 2 years. It was a cross-sectional analysis, a single point in time, utilizing data from their most recent visit. I should mention that this is the largest data set worldwide that collects this type of information about nosoplastic pain and fibromyalgia. So it's a really valuable resource to have been able to insert this questionnaire into the CRF, the clinical research form that patients fill out.
And what did you find? So what proportion of patients fulfilled the definition of fibromyalgia or widespread pain? And what other features were associated with fibromyalgia and pain in these patients?
Using definitions embedded in the 2016 version of the WPI and SSS, we found that 20.6% of the patients fulfilled criteria for widespread pain or nosoplastic pain. And embedded within this group, we found that 11.1% of the total data set fulfilled the more multidimensional features, including fatigue and sleep disturbance, which characterize fibromyalgia. The latter figure is somewhat lower than what is described in some other studies of various rheumatologic conditions in addition to psoriatic arthritis, such as rheumatoid arthritis or axial spondyloarthritis, in which up to 20% of patient groups may have concomitant fibromyalgia. This may be in part due to the fact that patients in the Core Evitas registry have their basic disease process well treated. And some studies suggest that effective treatment of the underlying rheumatic disease may be associated with lesser prevalence of fibromyalgia.
Yeah, if you feel better, I think is real. So your manuscript has a couple really interesting graphs to illustrate what you saw when you evaluated the psoriatic disease activity scores in those fibromyalgia groups. This obviously is an audio-only podcast, so I'm wondering, can you describe those graphs for our listeners?
We demonstrated that measures of disease activity, both single measures such as patient global, patient pain, tender joint count, and composite measures such as the C-DAPSA score were all twice as severe in patients with concomitant fibromyalgia and widespread pain than those patients who did not score high on the WPI and SSS. In addition, using a statistical method known as a Loess curve, we showed that this phenomenon was not a black and white separation between those who crossed the threshold to fibromyalgia and widespread pain and those who did not. One bucket over here, another bucket over there. But it was a continuum, suggesting that there could be plasticity in this state of being, which we want to understand better when in the future we look at this data set longitudinally.
Yeah, I think that's kind of one of the biggest take-home points from this manuscript, and I thought those curves were really compelling. What do you think this means in practice? How should patients and their physicians use this data to interpret their own disease activity in a clinical setting?
It is critically important to carefully assess the categories of pain present in the patient in front of you. Since we are moving increasingly in rheumatology to treat to a target of remission or low disease activity, there is the temptation, if the patient has not achieved such a desirable target because their composite measures are still high due to background fibromyalgia, for example, to consider switching from one immune moderating drug to another. But if the patient's inflammation is well controlled and their pain and fatigue is instead driven more by fibromyalgia, and they are unable to achieve remission or low disease activity, then it is important to reconsider your treatment plan. Perhaps keep the same immune treatment in place and move to a broader, more holistic treatment plan that can more effectively address central sensitization, including neuromodulatory medications, psychological counseling, exercise, and other modalities.
Yeah, I think that's so important in clinical practice. So you teased us a little bit earlier with one of your responses. This particular analysis that you're presenting in this manuscript was cross-sectional. It was a single time point, but you kind of suggested there might be plans to examine these fibromyalgia and widespread pain measures longitudinally to see if there are differences in treatment response. Can you give us any more information on that?
Absolutely. So we do want to study this longitudinally, and as we have more subsequent visits accumulated, we will be able to look at effects of widespread pain and fibromyalgia on treatment response over time, and we expect to see a blunting effect in those with these concomitant conditions. This is important for us to understand to aid our decision-making about therapeutic management.
Yeah, I think that's going to be so important, and I'm really kind of looking forward to hearing more about that in the years to come. So, Phil, I wanted to move on now to hear a little bit more about your life and your life in medicine and rheumatology. As I understand it, you didn't originally plan to go into medicine. In college, your strengths were in the humanities, but you had a life-altering moment that changed the course of your life. Tell us about it.
Well, Vicky, it looks like you've done a little bit of snooping into my earlier life, which I'm tickled by. When I was a sophomore undergraduate at Stanford, one of the deans there introduced me to I should step back. This was 1969 and 1970. Yes, indeed, I was involved in studying the humanities, but we were also involved in lots of political turmoil and so forth because of the Vietnam War. So I was involved with a group of people that were into studying nonviolence and the preachings of Gandhi and and the words of Martin Luther King and so forth. And so it was an idealistic time. And one of the deans that I knew well there sort of took me under his wing and introduced me to a old friend of his who, as a biology teacher in a free high school in Palo Alto, had been going down to this remote mountainous area of northwest Mexico in the Sierra Madre Mountains, and over time had taught himself medicine and became a health practitioner in this remote area that didn't have any medical care. So I met him, became inspired by his studies of his work there. And when he wanted to take a spell away from that work in order to come back and write and illustrate a book that became known as Donde no hay doctor, where there is no doctor, which is now kind of like a Merck manual of medicine for villagers all around the world and is published in literally every language. I took his place for 6 months. I was the sole practitioner for this group of villages in the mountains. I had a clinic full of donated medications, surgical, X-ray, lab, and dental equipment, and most importantly, a full library of medical textbooks, which is how I learned medical basics. I was fully plunged into the lives of the people of the region through their illnesses, both routine and grave. And indeed, it was a life-altering time for me, and I came back to Stanford, shifted into pre-medical studies, and never looked back.
Amazing. Amazing story. What drew you into rheumatology? Were there other mentors who guided you?
Absolutely. There were some very important mentors to me. One was when I was a medical student at Stanford, I came to know Hal Holman and Hugh McDevitt, both prominent rheumatology researchers. Hugh was my attending when I was doing a medical rotation, and Hal took me under his wing as he was doing some research on bringing rheumatology education to the community in conjunction with a nurse practitioner there named Kate Lorick. Then when I came to the University of Washington, I also was mentored by rheumatologists such as Bruce Gilliland, who was one of the editors for Harrison's textbook, Bob Wilkins, who was one of the early pioneers of use of methotrexate in rheumatologic disease, and importantly, a pediatric immunologist, Hans Ochs, with whom I published my first article, and he allowed me to be first author in the New England Journal on a case report of a patient being treated with immune globulin therapy, which ultimately altogether led to my wanting to become a rheumatology fellow and rheumatologist.
Amazing story. So you basically taught yourself medicine, taught yourself research before you even had gotten into rheumatology fellowship. Incredible. So what also struck me about your story is you did not then continue on that academic medicine, university-based track. You then, after fellowship, began a private practice in Seattle. You started back in 1982 and were seeing patients for many years before you kind of pivoted into, again, the research arena. What changed for you during that time, and how did you get started back into research?
So at the time when I finished fellowship, the opportunities within the University of Washington were mainly bench research-based tracks, and we really didn't have a track at the time for just plain old clinical rheumatology and clinical research. So I did go into private practice in conjunction with, and remain so, in conjunction with other clinicians at Seattle Rheumatology Associates, which is closely affiliated with the Providence Health System, which is a large health system in the western part of the U.S., from Alaska to California and Texas. I got the bug for doing clinical research on a regular basis in the 1990s when Dan First, a prominent person in the realm of scleroderma and rheumatoid arthritis research, who was also practicing in Seattle at the time, asked me to help him recruit patients for rheumatoid arthritis clinical trials, including use of etanercept, which had been developed by a Seattle company called Immunex. I was seeing a large number of patients with psoriatic arthritis being treated at a psoriasis treatment center with which I was affiliated. I approached Immunex with the idea of testing etanercept in psoriatic arthritis. They agreed to supply me with drug, and I conducted an independent investigator-controlled trial of 60 patients. The results were good in both joints and skin, and the study was good enough quality to publish in The Lancet. Since then, and 700 published articles later, I've had the opportunity to be involved in many research studies on disease state, assessment and treatment of diseases such as psoriatic arthritis, axial spondyloarthritis, and rheumatoid arthritis. I've even now ventured into doing big data, artificial intelligence studies with something called the Institute for Systems Biology, which is a Providence affiliate, and now deeply involved in CAR T-cell therapy studies in lupus, scleroderma, and other diseases with hematology, oncology collaborators here at Swedish and Providence. Alongside that has come a bevy of educational opportunities to teach rheumatologists, dermatologists, and gastroenterologists and mentor a number of young investigators through organizations such as GRAPPA, which I helped found in 2003 with Daphne Gladman, also Spartan, ASAS, and OMERACT. The balance of clinical practice and developing deep relationships with patients who I've come to know well over the years, and being able to be active in research and teaching yields never a dull moment and keeps me excited to go to work every day.
Yeah, no, and I think that's such an inspirational story and so important for some of our early career rheumatologists and trainees to know that there are so many ways you can take your career and still kind of have this full fulfillment in the teaching, research, and clinical care. I'm going to ask you a bit of a personal question now, because you've also been extremely successful balancing your work and your personal life. Your wife is a clinical psychologist. She herself is a very well-published author, and your careers really grew in parallel. I'm wondering, do you have any secrets of your success together that you would be willing to share for our listeners?
Sure. My wife and I really enjoy being with each other, and that has matured and evolved over the years. We have a great deal of respect for each other's work, the work ethic that we pursue, the enjoyment that we find in our work, and a drive to get things accomplished, even as we move into our older years. We really enjoy the bounty of the Northwest, its ethic and environmental consciousness. Our children who went out to for schooling and work in other parts of the country, but now have rejoined us here, our friends and colleagues, art and culture. I get to play the cello in a variety of settings, which is a nice escape from just working. And included, and that would be at the recent annual GRAPPA meeting that was held here in Seattle, where I teamed up with Ian McGuinness, who is a prominent rheumatology researcher from Scotland, and as it turns out, a former opera singer, in a rousing version of Leonard Cohen's Hallelujah that we did as a cello and vocal duet. My comment, live life fully and follow your passions.
That's amazing. And I did not know that about Ian McInnes. And you've just given me another tip for someone that we should invite on the show. So one last question. What was it like when you became made a master of the American College of Rheumatology?
It was a great honor to be elected to master status in the ACR. I think the ACR is a terrific organization that promotes and presents high-quality research and education and is a driving force to advance all aspects of rheumatology and strives to bring rheumatology care to all who need it in the population.
And tell us a little bit about the process of being elected to the master role. I think it involves kind of nomination from a number of peers. Were you aware of that process? Did it happen under, veil of secrecy?
Well, you're right. I was not aware that I was being nominated, and it came as a surprise and, again, a great honor. I think it's an important designation for the college to recognize people who contribute to research, to education, to clinical care, and overall advance the field of rheumatology.
Yeah, no, I really agree. And I want to thank you so much, Phil, for sharing all of your research, your life advice, and all of these amazing experiences with us today. I really enjoyed this discussion.
Thank you, Vicki. I really appreciate the opportunity to have this discussion with you.
My thanks today also go to patients who sign up for longitudinal research registries. These initiatives provide real-world data that is incredibly valuable to researchers who are trying to understand the complex interactions between symptoms and disease activity over time and across the lifespan. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.